morning, everyone. Pleasure to have you here for this second day of the CARE Summit. My name is Federica Margheri. I'm the Executive Director at the European Health Management Association, and I'm delighted to see you here today for this second day, which is about starting co-creating the roadmap.
And good morning from me as well. I think you heard enough from me yesterday, so I'll be brief. But for those of you who are just joining us, I think for the second day only, there may be a few of you. I'll give you a bit of a reminder of what we talked about yesterday, just so we can kind of refresh ourselves and get started with this new style of workshop, kind of more interactive day that we have planned. So yesterday, I mean, it was a bit refreshing for me and hopefully for a lot of you to hear from a lot of different perspectives. We had people from the military and cybersecurity, local regional health authorities, a few clinicians talking about a lot of different topics that relate to Europe's strategic agenda. And of course, we're here because a lot of us, well, I assume all of us in the room are really focused on health and the work that we do. And I think it's important that we come together as a community to really raise our voices and show health has a place in this. All of these aspects like defense and data security or the use of data, there's a lot of places where health should not be neglected, and it's nice to see you all here to help us spread that message. So with that said, I think I'll have you introduce the format for today and we can get started.
Yeah, indeed. So today is going to be a little bit different from yesterday. Yesterday was more about letting you hear from a few speakers, whereas today I would like to turn to you, so we will be the one listening to you. Would like you to share some of your experiences, whether in your regions, in your territories, in your organizations. Would like to learn more from things or case studies or situation that went well. But also situation, case studies that maybe didn't go as planned, because we can learn a lot also from things that don't go as we initially expect. And so the original plan is that after this plenary session, we're going to split into 3 groups according to 3 themes or tracks. However, because we are seeing if a few people may continue to join, if we don't reach what could be a critical number, maybe we do a collective brainstorming session on these 3 tracks. So we'll see how it goes. So we'll let you know after the coffee break, because we do improvise a little bit. But the point is, whether in split into different tracks or whether all together, we're still going to address all the tracks and we'll still want to hear from you. And so to get us started and in line with our improvisation of the day, we have thought of giving you a little bit of a food for thought to start the discussion on these 3 different tracks. And so we have 3 presenters, currently 2 in the room, so hopefully they will become 3 very soon. So we have 3 presenters that will present 3 case studies, one on each of the 3 tracks that we're going to address today. And so the first presenter is Beatriz Barros from Cienzano. Beatriz, please take the stage. Here is your clicker, and the microphone is there. And so Beatriz is a health policy researcher at Cienzano here in Belgium, and she will speak about track D, which is the European health data space. Beatriz, over to you.
My name is Beatriz, as introduced. I work in Cienzano in the Innovation in Health Information Systems unit. Today I was invited to present a use case. So we have discussed already a lot yesterday, these big overviews and big visions of the HDS. Today I want to focus more on the implementation efforts we are doing, and I will guide you to a bit of our experience creating a metadata framework for the EHDS. We all know that data nowadays is the center of all of our discussions, our meetings, our agendas, our events, and we see now this more and more this idea of taking knowledge and the value of the data. And we have the example of the recent European Data Union strategy that presents data as a strategic asset for innovation, for growth, for competitiveness. And we have this big vision of the common European health data, the common data spaces, where is introduced the European health data space, and we have this ambitious vision. But when we look at the health data, we see the problems, and we all know the barriers. I'm seeing some formatting problems, but I hope the message passes well. But we all know the barriers. I will not go into it because we have already discussed a lot. We know this is a complex system, and we need to have the technology, the data management practices, the trust, the legal framework to make it work, and that's where the EHDS pretends to come and respond to some of these legal issues. And we have, in the previous years, work on assessing these needs and creating the legislation to start to respond to these needs. And we are now in a critical phase of actually implementing and putting the stakeholders together and creating the technology, validating, and then be able to scale it. So that's the current standpoint, and we have a lot of efforts going into this objective. We have at the EU level several initiatives. I highlighted here some of the ones that are currently or past, like TEDS, being developed, but also if you look at your national level, there's a lot of parallel efforts. We have the direct grants for the creation of HDABs at the national level. There's also a lot of different initiatives to develop this framework. So a lot is happening. Today I will zoom in the TEDS2 joint action that I believe many of you know. It's a joint action, so we have representatives from almost all member states to try to create the foundations for this harmonized implementation. And we touch in this project in a large variety of topics. We have groups of people working on the data preparation, so looking at anonymization, pseudonymization, how to prepare the data, when and how, who does these operations. We also importantly have a group dedicated to secure processing environments, understand what type of requirements do we need in these environments, how to make it work. We also have collaboration models, the focus on the citizen, the opt-out, significant findings. So a lot of work is being done. Today I will focus on the work that we are doing in data discovery. I put it here to explain that this is important because all of this work is then now feeding directly into the implementing access we are seeing now with the start of the discussions of the comitology. So this is a direct link between the project and the discussions towards the implementation. But coming back to the data discovery, when we started this work, the key point was to look into Article 51 that tells us what are the categories of data that we need to describe for secondary use. And we find there 17 categories of data. So we are not just talking about electronic health records, but we are talking on a large variety and different domains within the health data. So we have genomic data, but we also have data from medical devices and social environmental determinants, pathogen data, genomic data. So it is a lot of data, a lot of stakeholders, a lot of organizations that are involved in this. Because we also, this comes with the duties associated with the data holders to describe this data, and the duties to the HDAPs to make this data available in a catalog, in a standardized way, and in a machine-readable way. So it's a lot of duties and a lot of data. And the question here to start was, how can all of these data holders involved in these categories of data describe this data in the same way? So this is the starting point, and the answer here is to have a common and harmonized metadata model, and this is exactly what was done. It started in the Health Data at EU pilot, where an expert group was put together to understand what type of information do we need to describe health data. And from here, the outcome was the first version of LTIC at AP, the name of this model that is being suggested and discussed for the metadata model for the HDS. Then TEDS2 started, and we validated this model in a larger community, because as I said, we have representatives from a lot of member states. And here we had very rich and interesting discussions, because in TEDS, we are not in an expert group anymore. We are expanding this to a much larger community, and we can see the differences in different countries, in their political views of the data sharing, in the cultural differences. And here it was already a wake-up call to the need to test this conceptual framework that we were creating in a real environment. And we more or less did that in the public consultation that we have in TEDS. all of the outcomes from TEDS go into public consultation first, so create a draft that goes into public consultation. And this was, again, a very, very interesting outcome. I could be here 1 hour talking about the results from the public consultation and all of the feedback that we received, positive and not so positive. So I had to choose some topics to highlight. The first one was the detail of the content. So it was truly a mirror to the diversity and the maturity that we have in the different member states. Because we received some comments saying, this is great, but this is too simplistic. We have very complex data sets in my country. We have a whole data warehouse. We have metadata practices happening in real time, and we have this system figured out, and we need more technical details to make your vision and to understand the vision that you are proposing. But on the other side, we receive other comments saying, this is way too technical. I need much more support before this. I need to understand, first of all, am I a data holder in the HDS? What type of data are we talking about? Then I need to understand what is this about the metadata. Why do I need machine-readable metadata? What is the vision? I need more background information. So here already we see two different feedbacks. Then we also understood that we were needing to go into more granularity in these discussions, because we were discussing this data set description, and a major comment was, I need to be able to make variable level descriptions, especially if we want to consider these data minimization principles. I need to be able to go deeper into the description of my data sets. And this was also a big discussion that we had about the variable level, because here we need to consider that we are creating work, and is a lot of burden for data holders. This is burden for data holders is a key sentence when we are talking in TEDS, but it's a real challenge. So we had to balance all of this. And it made us see that the original document was not enough. It was not enough what we were providing, nor for the more mature data holders, nor for the ones that were starting. So we had to tackle these different needs from the different data holders, and we created a refined version of this document. First of all, it includes a clarification of all of the categories of health data that are in Article 51, and this was made through a truly collaborative effort from all of the partners in this task. We did a workshop for each one of the categories. We discussed in depth what is this data means, because in the regulation you will find quite a vague description, a very large description, and we need to discriminate it a bit more to make it understandable. So we will find this here. Then we also have a new section to describe for data holders what are these obligations, legal requirements to describe the data. And we explain in different levels of maturity what is the role of metadata on this, why do we need machine-readable data, what is the vision with the catalogs, and how can this all of this framework be implemented in practice. Then we introduce LTKTP, and we need to change completely the way we approach the explanation of the model and be more concrete. We were providing a conceptual framework, and this needs to be practical framework. It needs to be complemented by real-world examples, and we need to explain the rationale behind the methodologies that we are proposing. So we complemented these by going into each one of these properties that we are proposing to describe data sets in LTKTP with practical examples. And here it was truly improved by the insights that we gathered from the public consultation, because we could map, okay, this property has a lot of questions raising, it's not clear how can this be translated to practice. We need to put this in the context of examples. So that's exactly what we did, with a lot of work from everyone involved. And now we have a detailed description for each one of these properties with real-world examples. And we have been receiving a lot of good feedback on this document, and good feedback from data holders telling us this really helps in giving guidance in all of these aspects: the initial background, the context, the scope, the legal obligations, and then in the model itself. So it shows the power of getting this knowledge and refining and understanding in the middle point. Are we doing this the right way? And more than just the report, we can see already how this is being implemented in practice. If you have been recently to the Health Data at EU Central Platform, this is release 5. I think now we have already, will be in January a new release. But you can see in practice already LTKTP implemented, and you can see that the information that we are requesting from data holders in the model is then being applied in the user interface through filters and to advance the search capabilities of the catalogs. So it helps to see the actual implementation of the model that we are proposing. And another victory of this project is that in the latest release, we also have the list of variables in the dataset, because this was truly a big discussion on the variables and the need for the variables, and it was very highlighted by data holders, by data users, and we communicated a lot of this with our colleagues in the European Commission to truly stress the need for this information, and we can see now that it's already starting to be implemented. So this is a positive way to show that there are progress and we are making progress, not only on these initial and more conceptual discussions, but also in the actual implementation that is being done and guiding a bit this technology framework. I also wanted to show that one of the key feedback that we received from data holders, not so related to the guideline, was related to the whole ecosystem, that data holders need tools. This needs to happen to tailor tools to data holders, that we can streamline the process, that we have user-oriented tools that allow data holders to make these procedures. And this was also very communicated, you find it in the final considerations of our deliverable. We highlight the key topics that need efforts for the future implementation, and tools was a big one. And now also in the new release of the Health at EU Central Platform, you will find a space dedicated to tools, and we have already a preliminary version of the editor to create metadata, and a lot of the support descriptions are based on the deliverable, so based on the needs identified from the public consultation. So I hope you can see what I see is that this is all feeding into each other, and we make this mapping between what the data holders and all the stakeholders identify is needed, and we try to map it as much as possible to the implementation efforts. So slowly, it's coming together in that sense, and that we are able to progress this information and share the knowledge. This is the efforts at the European level. Today I brought here the example at national level of Belgium, because we are in Belgium and I work in Belgium. And we in Cienzano and my colleagues have been working very hard on also creating support for the national stakeholders, and we have our health data literacy platform with a lot of documentation, guidance, but also tailored tools. And this is an example from our organization, but I'm sure that in all of your member states, in the organizations of your member states, there's also a lot of national efforts being made. So I encourage you to follow the people and the organizations involved in this work, because there are a lot of work also being done at the member state level to help data holders. And we get to the lessons learned, and this is a bit cliche, but I think the main lesson learned here is really the value of co-creation and co-design and co-development of this type of solutions. So trying always to make sure that we are not just developing a conceptual framework very siloed within one project and one joint action, but to expose it to the community early on and make several rounds of getting feedback and then understanding how can we improve this, how can we really respond to the needs of the stakeholders, because that was the lesson from our public consultation. We were not answering the needs of the stakeholders. And of course, we cannot answer all of the needs. That's also a lesson learned, is that this is a project that will end, and we have a bit of a limited scope in this big scope that is the HDS. And that's sometimes a bit a frustrating experience, because we want to be able to respond to everything, but it's not possible, and that's why we are going into TEDS 2, but probably there will be a TEDS 3, 4, 5, and we are continuously refining these topics and implementing better and better solutions. So this was a key takeaway, but we see really the value of involving all of these stakeholders, and what we take from here is that we need more and more to involve every actor that is affected by the EHDS, is involved in the EHDS. And here I'm talking about the usual suspects, the HDAPs, all the data holders in the different member states. But also yesterday, we were talking a lot about the common purpose and the common objective. And here, something that we've been discussing a lot is that we need to look into community-specific developments. And we have a lot of great examples. And here I'm talking and thinking about the research infrastructures. We have BBMRI, eBrains, ECRIN, that have years of experience developing these very tailored catalogs, services, tools, and know the community and know the needs. And also emerging infrastructures that are being developed. EUCAM, big infrastructure, GDI. So we have a lot of examples. At this point, we needed to keep it high level because at the end of the day, this needs to be a solution that is implemented through 17 categories of data, through a lot of data holders. But the next step is to really refine these tools and to be able to work with the different communities, not only to get the knowledge from these years of experience in these communities, but also to leverage the services they are providing, the tools that they developed, and to make sure that we enter in this ecosystem that is already moving. It's not just starting with the HDS, there's already years of experience. So the HDS brings these legal obligations, but is also this prompt for us to innovate, to create interoperability, to create this streamlined approach to data reuse. And that was the big message that I wanted to pass in our experience. Last slide to let you know again about these public consultations, because not only we need the feedback from everyone that is involved in the health data domain, we need the feedback is the way that we improve our documents and that we make sure we are responding to the needs identified by the stakeholders. It's not so visible, but we will have the last round in May. In May. The second round just finished. We had 11 documents in this second round, so we have a lot of work to do now to processing all of these comments. But in May there will be the final round, and it's going to be, again, a lot of documents. So if you want to keep the developments, it's all very transparent and open. Is quite straightforward to understand what we are thinking, what we are developing, and your feedback is the way to go to make sure that this is as real and as strong as possible. So this was all from my side. Thank you so much for your attention.
Thank you, Beatrice. And I don't know about all of you, but the more I learn about the amount of work and the complexity of work that's going in and around the EHDS, the more respect I have for people who are working on it. So thank you for being here.
Well, and then we go to our next speaker for the day, which is Lisa Baldini. Lisa Baldini is a project manager at Agenas. Agenas is the National Institute for Regional Health in Italy. Perfect. Okay, so she will she will then tell you the correct translation. So Lisa will speak about a case study from one of the project that she manages and that Agena is in charge of, which is the HEROES project. And the track that she is addressing is track A, so crisis preparedness and cross-border cooperation. Lisa.
Thank you so much, Federica. Good morning, everyone. It's a pleasure for me to be here with you. My name is Lisa Baldini. I'm the project manager of the Joint Action HEROES. But today, here with me, there is also Dr. Marco Di Marco, who is the scientific responsible of the Joint Action. So first of all, I would like to inform you that HEROES is not the first project on health workforce, but it is the result of two important predecessors. That was the first joint action on health workforce planning and forecasting between 2013 and 2016, and second joint action between 2017 and 2020. So it's very important to highlight that we are building on the results of these two important projects. These are some, there is not a picture here. Okay, so these are the main objective of the project. So it's to improve member state capacity to plan for the health workforce, to ensure the accessibility, sustainability, and resilience of healthcare services. We have 19 European countries with a total of 53 partners, a budget of more or less 9 million euros. And the joint action started on 1st February 2023, and it will last at the end of July 2026, so more or less 3 years, but we had just obtained an extension of this project of 6 months. This is the general structure of the joint action. So we have 7 different work packages. We have the work package 1, which is the coordinator, agendas. The work package 2, it's about the dissemination and communication of the activities. The work package 3, it's about the evaluation. The work package 4, it's about sustainability. And then we have what we call the learning cluster. So all the different participated countries were divided at the beginning of the joint action into different clusters, according to the similarities that they have in terms of their national healthcare system. For example, in Work Package 5, you can see that we have countries with a public healthcare system. Italy, Sweden, Portugal, and so on. And why do this project exist? Because nowadays we are facing different challenges of health workforce. So for example, shortages, maldistribution, skill mismatch, and the need to be flexible, agile, and respond to the crisis. So it's very important. And we are working on 3 different tasks plus 1. So the first one is data, optimizing planning data and sources. The second one is optimizing planning model and tools. And the third is the development and the improvement of the skill of the planners. Of course, we have the fourth, that is the involvement of the right stakeholder, because you know better than me that it's very important to have the right people at the same table to discuss. These are the 3 phases of the project. So the first phase was the as-is phase, in which all the countries had to describe their current situation at the beginning of the joint action in terms of data, model, and skills. And we created an important document, the as-is report, the description, a sort of picture of that moment of each country, the cross-country comparison, because we thought that it was very important to compare the country within the same cluster, but also the cross-cluster comparison. So it's very important to compare also the country across the 3 different clusters. And then we have the to-be phase, in which all the countries creating important documents called action plan, document in which they had to state the objective with the related strategies and timeline. And now we are in the to-do phase, in the last phase of the project, in which we are implementing our action plan, but we are working on different activities. For example, policy dialogues. Policy dialogues are very important meeting that each country has to create at national level. They have to bring together not only the technical stakeholder, but also the policy level, so the policy stakeholder, because it's important to create a dialogue between these 2 different stakeholders. And then we have the international mutual learning, because it's important to exchange good practices among countries, and the sustainability process that we are doing with the support of WHO, because you know that it's crucial to bring the result of a project also after the end of it. This slide is just to let you know at the beginning of the joint action, of the mutual learning activity, how many interactions that we had across all the countries. But now it's an old data, because now all the countries are planning or have activated bilateral meeting. So we are pushing a lot in terms of this collaboration among countries. And now I want to just give you some example of good practices that we are having and mutual learning results. First of all, a very important good practice that we have is that Hungary, University, which is our leader of task 1, which is data, they created an advanced minimum data set. You have to know that during the first joint action on health workforce planning and forecasting, they created the minimum data set. And now they improved. They have created the advanced minimum data set. It's a very important tool that is able to distinguish the maturity level, the complexity level of each country, and allow each country to evaluate the necessary minimum data requirement. I heard yesterday some of you talk about data. So someone say that we don't need more data, but better data. So I perfectly agree, and it is the case. And then this is a very important example of mutual learning result that we are having. You have to know that Netherlands is one of the most developed countries in terms of planning tools. So they have one of the most developed planning tools in HEROES. And thanks to this, Malta has officialized a bilateral partnership, and it is actively implementing the NIVEL model. So the strategy of Malta was, first of all, to have a robust and centralized data. And we recognize that the starting point of planning is data, to have better data, good qualitative data. But they were able to, and they wanted to harmonize this data across the entire Ministry of Health of Malta. But data alone is not enough. We know that we need a tool to put data, and they were able to implement, we can say copy, to develop and roll out the model that is being used in Netherlands. And they were able to do it with the support of WHO also, with the European Commission and also HEROES project, because they are doing it within the HEROES project. So this is a very success story that we are having in HEROES. And this is another result that I want to show you what we are doing in Italy. So we are working on 3 different issues. The first one is we are trying to improve our national forecasting model. The second one is we are trying to have a fully integrated statistical information system. And the third is to better use the methodology to define the staffing need at organizational level. These are the 2 models that we have. So the first one is the national forecasting model that was developed by the Ministry of Health in 2015, and it is the result of the first joint action in 2015. And it's a forecasting model, so it covers all the 30 healthcare professionals we have in Italy. It is a stock and flow model, and I want just to show you how it works. So you can see that we have several variables that affect the supply side. So we have a very strong supply, you can say, but a very weak demand. And this is why the international collaboration is important also for us, because we are trying to have a bilateral meeting with HEROES countries to try to see if their model have more variables from which we can take inputs. And then we have the second model, which is a model developed by Agenas, and it is aimed to define the staffing need at organizational level. Our aim is to try to improve our national forecasting model in using the Agenas model in trying to define, we want to use this model to better define the demand of our forecasting model. And on the other side, we want to use the international collaboration always to improve our demand side, because we realize that it's much more complex to define the demand rather than the supply. Because if we know how many doctors, how many healthcare professionals we can provide in the future, we cannot see the health challenges that we can face in the future. And in HEROES, we saw that all the models that we have in HEROES have very strong supply but weak demand. So it's a common challenge in all HEROES countries. So just to sum up what we are doing in Italy, so we are using our methodology to define the staffing need at organizational level. We are using the international mutual learning activity to better define the demand of our national forecasting model to have a more accurate health workforce planning for the crisis preparedness for the future. If you are interested in HEROES, this is the website you can visit, and this is the email you can write to if you are interested to know something more. Thank you very much for your attention.
Thank you, Lisa. And I think this is a great example of how we can leverage European collaboration to solve some of these complex problems. So thank you for being here and sharing.
Well, thank you again, Lisa. And now we go to our third speaker that probably you have seen because you've seen his picture appearing. So it's Dr. Matthias Wismer. He's a program manager at the European Observatory on Health Systems and Policies. It is to be said that Matthias is stepping in for a colleague, Nicole Mauer, technical officer at the observatory, because unfortunately Nicole is not well today. So Matthias, the clicker is yours, and also the microphone.
Thank you so much. Yes, good morning, everybody. I'm very sorry that I have to replace Nicole, but she asked me to convey her greetings, and we hope that she will recover very, very soon. This topic is actually at the core of the debate on One Health approach, because it's about greening health systems, where it all comes together: health, environment, and climate. And the way we are looking at it is to think about, how can we actually marry climate change and health systems. And the subtitle is, how can healthcare facility reduce their environmental footprint and contribute to more sustainable health systems? And that's a bit the theme of the presentation, that we are not only sorry about this, that we are not only trying to mitigate climate and adapt to climate change, but also try to make health systems more efficient. And this is just to give you a little bit of an overview what climate change means. Of course, in the first place, it's health risk like extreme weather events, health, sea level rise, air pollutions, vector distributions, water scarcity, reduced food production. You know all this. It's quite a horror show, actually, for many countries. But people are reacting to it differently because they have different profiles. You can easily think about elderly people, exposed to heat, suffer much more than younger people. People with certain preconditions, have much more difficulties to cope with weather events and so on. So there's quite an inequitable distribution about the effects of the climate change. And of course, exposure also plays a role. If you work in a climatized office, it's very different than you are, for example, a manual worker outside building bridges or whatsoever. And just to be clear, the climate change is causing a large variety of health conditions, and we start actually with injury. Sounds surprising, but think about the flooding in Valencia. People died actually from the climate change. We have heat-related disease. We have respiratory illness. There's always a discussion on ozone gas in the summer, which causes problems. Waterborne disease. Yesterday, in one of the breakout sessions, we were talking about zoonotic diseases and vector-driven diseases in great detail, and I could go on like this. So there's plenty of issues which is caused actually by climate change, but it's not just a one-way relationship. It's a bi-directional relations, because health systems, on one hand, they contribute to the climate change. Just think about the greenhouse gases we are emitting, but they could also mitigate it by reducing the greenhouse gases. And of course, it's a big topic. It's also a big topic for WHO, which have issued some sort of guidelines, and many countries are actually drafting or have already drafted policies, to mitigate climate change. And I go with you very quickly through these 7 points, which are the strategies which have proven to actually work and make really a difference. And the first one is, we just need to acknowledge, the health sector is vulnerable to climate change. In many places, we don't have air conditionings, for example, Probably rest homes, nursing homes are even more affected by this, but hospitals are also affected, and in many places we need to have air conditioning, but also directly responsible for around 5% of global greenhouse emissions, and this is global. So there are large variations between countries. Some countries, OECD countries, have probably 8 to 9% global emissions, which makes it a very important sector, to try to reduce the global greenhouse emissions. Decarbonization must be pursued across the whole sectors and at all levels, from the system down to the healthcare facility. And I give you an example from a Swiss hospital where the authors have looked into the proportions of the global warming potential. And if you look at this, the biggest potential is, of course, in the heating. You need to get the heating right in a hospital, but also the catering accounts for 17% of the global warming potential. And building infrastructure is also a very important issue here. But you can see it around these 12 categories, that almost in every corner of the hospital, you have potential to address the global warming. Next one is, at health system level, greening generates multiple co-benefits for population health. And this is very important to understand. If we are greening the hospital, we can have better results from healthcare, actually. And the first thing is the demand-side policies. We need to invest in health promotion and prevention, in patient education, health literacy, of course, public information, and so on. And the idea is that we defer the onset of chronic diseases and of multimorbidities by a couple of years. And if we manage to do this, actually, then we see less people in healthcare facilities, we see less people in hospitals, and this will contribute to a reduced use of health services and a reduced production of greenhouse gases. But there are also supply side issues, and I will talk in a minute about recycling, reuse, and all this kind of stuff, but I want to draw your attention to system level mitigation strategies, which is, first of all, shifting care to less polluting settings. And a very polluting setting, unfortunately, is the hospital. So maybe there are others. Maybe there are home visits, maybe hospital at home, maybe the primary care practice or the primary care center is the better place. Minimize low-value care. This is something many health policymakers are at the moment very concerned. They realize that there are a lot of services delivered which actually not really contributing much, which are not really good. So how can we get rid of this stuff to reduce the use, but also the overdiagnosis and treatments? We have very often the problem that you get an X-ray and you go to the next specialist and you got another one, and there's a lot of diagnosis without actually any action taken afterwards, and we need to clearly reduce this. So if we achieve this, the climate action health systems will lead to better care quality, efficiency, and it will also reduce the greenhouse gas emissions. So this is a win-win situation, and I think we should really work on this strategy very hard. The next one, the fourth strategy, at healthcare facility levels, the sector's environmental footprint can be reduced by a lot of things. First of all, green spaces and infrastructure. It's a very simple thing, actually, trying to get rid of too many parking lots and having more trees, having more green spaces. Solar panels, there's plenty of opportunities for it, the lighting, the water recycling, the waste management, and of course, energy efficient ventilations. We are sitting in an office building where the ventilation is really not energy efficient. It's not efficient at all. It's even cold sometimes and sometimes very hot. So a lot could be done if we improve this one. But also green procurement, pharmaceuticals. At the moment, many hospitals are phasing out the use of nitrous oxygen, what is it called? Laughing gas, something like this, for anesthesia, because it's an immense danger to the climate. But also medical devices. We still have many old MRIs that are using a lot of energy, medical equipment, and so on. Green mobility. It's not a good idea to build a hospital outside the city, far away, where people need to go by car. And it's not just the patient, it's also the health workers, it's the families, that everybody's going there. And of course, walking would always be the best solution, and bicycle riding is also great, but you cannot expect the patient riding to the surgery. But maybe for some of the health workers, and then you need to make very clear for public transport, that the public transport is very well organized for your hospital, and maybe some car sharing. Driving is the least desirable option. Waste management, really very important issue as well. It's the 6 R's: reduce, reuse, recycle, refuse, rethink, and repair. So these are the strategies which are in this part. Now, you can see that for introducing this in healthcare facilities, we need a lot of new competences and skills, and we need to think about how the health workforce can actually acquire this, because they are meant in the end to implement all this. And we have written actually a policy brief, because in a way, we see there are really effective strategies for greening health systems, but the implementation very often falls short. And one element, not the only one, but one element is the green skills. And we've done this together with Emma, with Federica and colleagues on green skills for a sustainable future. And there are very different skills actually which are necessary. Some of them is general knowledge on sustainability. It's almost like a climate health literacy, which is not only needed by the health workers, but actually also by the patients and by their families and caregivers. Transversal skills related to sustainability, technical skills, planetary skills. We're coming here back to the One Health issue, and environmental impact of healthcare. The policy briefs are all downloadable from our website, actually. Now, let me come to the next one. Oh, sorry, this one. Yes. Actions at healthcare facility level are often feasible but require adequate support at system level, including legal, strategic frameworks, technical expertise, and funding. And just one thing, you know, you're not alone, you're not left alone, actually. There are funds available at EU level, and I'm quite sure also in most countries, you know, are funds available. And just to show you, funds mainly coming from the Recovery and Resilience Facility, from the Cohesion Facility, but there's also Invest EU and the European Investment Bank. And sometimes I feel this is forgotten, you know, it's a very useful way to lend cheap money. The European Investment Bank also provides a lot of loans here. Now let me go to the case study, because this was all concepts and really interesting concepts, but what is happening in real life. And I've picked out Nicole has picked out two case studies. One is on a hospital in Barcelona, and it's the largest healthcare organization in Catalonia to conduct a voluntary carbon footprint assessment. So key actions, energy transition, 100% green electricity. How do they do this? Photovoltaic panels, solar park. You may say that's great for Barcelona, but maybe not for Brussels, where the sky is very often gray. But still, I think that we can learn from these examples. Sustainable mobility, patient SMS for public transport routes, affordable parking near rail, awareness campaigns. These are no-brainers, actually, and they don't require a lot of activities. Of course, the hospital cannot choose, oh, we are not in a good place, let's move to a better place, but they can still try to facilitate better transportation. Circular economy, reusable, searchable textiles, and look at this, 160 tons waste saved a year. This is quite substantial, actually. Reduce single-use items, food waste project, 47% surplus cut, 5,522 meals donated. And there's also always an element of research in it, big data and AI studies on climate health impacts and so on. The funny thing is, we published a little bit earlier a case study on a Toronto hospital, and it's almost the same. They almost do the same, and they continue to do the same. And talking about the skills, actually, we had 2 years ago a hospital director from the UK with us, and her only thing was to calculate and model, you know, the efficiency and efficiency gains coming actually from these strategies. Okay, case study, Ireland's whole of government approach. Context, 2015 Climate Act laid foundation for cross-sectoral action. They have national targets to halve greenhouse gas emissions by 2030. And the Health Service Executive, which is the arm's length body, the agency, like a little bit at Janus, you know, which is actually running the system, you know, is working on it. And the priority areas are sustainable buildings and green environments, infrastructure decarbonization, transport and mobility, sustained procurement, greener models of healthcare, water and waste management. You see, it's quite similar, and there are many countries now that are drafting or have drafted similar plans trying to go forward. We still hear that there are issues, of course, because some of it requires investment, even though some saving may come afterwards. And also the other issue, what we've heard, is that the training of the health workforce in healthcare facility is problematic because, as you know, we have a health workforce crisis, and very often the management says, in this situation with a crisis, all hands on deck, we don't have really time for the training. Oops, here. So, it's not that gloomy, actually, the picture, if we look where we are, but there's a lot of room for improvement, and I'm presenting here a study from last year, which was looking into different dimensions of moving forward greening health systems, and it's about the assessment, it's about emission assessment and action plans and all this. So you can see the yellow stuff is not yet conducted, but the green stuff is going forward, or it has started at least. And I think this is a rather positive picture, you know, that care organizations are trying to move forward. And we had yesterday in one of the breakout sessions actually Maria speaking, who is working very much on climate and management, actually, you know, bringing these two things together to make sure that in healthcare facilities this is going to be picked up, and that the win-win situation which exists between climate mitigation and health systems efficiency, that they are really kind of realized. So thank you so much for it. I'm very sorry I'm not Nicole. She would have done it much nicer than myself, but I hope it gives you a little bit of a flavor and enough food for thoughts, and please download, read, and like us.
Thanks, Matthias. We're more than happy to have you step in Nicole's place, and indeed it's a bit of a scary existential problem, so thanks for bringing some optimism and showing us there's some things that we can do and indeed are already being done.